when they're swallowing, please instruct them on doing that. Plan activities and rest carefully. Weakness is usually greater for them at the end of the day. Now, when we have a spinal cord injury patient, our main thing we want to do is immobilize and stabilize. Okay? Spinal cord injury, immobilize and stabilize. You want to remember that. Okay? You want to know the level of the injury because above C8 is quadriplegic, below C8 is paraplegic. You want to remember that. So these symptoms that you're going to see: hypotension, bradycardia, can occur in injuries above T6. Spinal shock, that's the temporary loss of sensation. Reflexes, usually it lasts greater than 48 hours up to several weeks. Okay, and then we expect for those reflexes to start coming back. Okay? Now, we start with the ABCs with spinal cord injury patient: airway, breathing, and circulation. We're going to palpate the scalp and touch the scalp because we want to see if there's any fractures, depressions in the skull. You want to know their respiratory rate, their neurological status, their vital signs. So we're doing a neurovascular assessment, our physical assessment with vitals. Okay? We're looking for bowel and bladder function. We're assessing for paralytic ileus, and we're assessing these psychosocial changes. So again, I already talked about the ABCs. Flaccid paralysis and neurogenic shock. You need to know what that is. Okay. Flaccid paralysis and neurogenic shock. It's a complete loss of reflexes with hypotension, bradycardia, bowel and bladder distension, and you want to reverse it as quickly as possible. So if they can't void, it needs to be straight path. If that's a problem, reverse it as quickly as possible. Autonomic dysreflexia is a medical emergency with injuries at or above T6. Notify the doctor immediately. There's exaggerated autonomic reflex response, usually triggered by bowel or bladder distension. You have signs and symptoms of severe headache, increased blood pressure, bradycardia, flushing, and profuse sweating. Elevate head of the bed while maintaining correct alignment, and relieve bowel or bladder distension. Okay? Now, when we're looking at rehab, we're monitoring for a paralytic ileus. We're assessing those bowel sounds. We're going to put them on a bowel and bladder program. You want a kinetic bed that has that airflow that's going to help with their circulation, because we don't want them to get any pressure ulcers. Okay. They're going to get SCDs and TED hose because we want to prevent DVTs. We want to protect the skin from breakdown. We're doing psychosocial assessments, and we want to keep the bladder empty and the urine dilute and acidic to prevent urinary tract infections. Now, when we're looking at fractures, we have 5 P's in fractures. Okay? Does anybody remember those 5 P's? Pallor, and pain. Okay. Y'all got it. Okay. And there they are. Okay. Pain, paresthesia, pulse, pallor, and paralysis. So we want the patient to have the correct assistive devices. Okay. So we're gonna consult with an interdisciplinary team: physical therapy, occupational therapy. Okay. We're gonna make sure that they're safe. If they have walker or crutches, of course, again, we're gonna move things out of the course of their walking path. We're assessing for skin color, temperature, sensation, capillary refill, mobility, pain, pulses, and compartment syndrome. Okay? Now, they can come back After surgery, they can either have a closed or open reduction. They might have a cast, they might have traction, external fixation, splits, or braces. Okay? Let's answer this question. Correct answer is 3. Okay. A is the first one. Okay. Correct answer is 3. Now, what you see here is a hip. It's a joint replacement. Okay. If a patient has a hip replacement, we want to keep the body in proper alignment. There's some things you will tell your patient not to do. One of those things is crossing their legs. Okay, we don't want them to cross their legs. We don't want them to adduct, okay, because they can pop that hip out of place, okay? So you need to remember that. Encourage fluid intake. We're also gonna encourage using the commode chair. If we give them a bedpan, it has to be that fracture pan. That's that black bedpan, okay? Instructions for discharge home, safety and accessibility, and then medications, anticoagulants, analgesics, and parenteral antibiotics are given. Now, with an amputation, the post-op care, remember I told you we do have to treat phantom limb pain because it is real to your patient. We also monitor, we want proper body alignment with an amputation, okay? Elevate the residual stump for 24 hours. Do not elevate the stump after 48 hours because what? We don't want hip contraction, okay? Because if that stump stays elevated, that hip joint can lock. We don't want contraction, okay? Pain control, like I said, phantom pain is real. We treat it. We do passive range of motion. Encourage the prone position also because that also helps decrease the risk of contraction. Proper stump bandaging, coordination of care with OT, PT, and social worker, and then assess and address breathing, as they have lost literally a part of themselves. Okay. Osteoporosis, risk factors, small boned females, usually they're of Caucasian descent, Asian, pregnancy and breastfeeding are risk factors for osteoporosis. Okay, family history, diet low in calcium, excessive alcohol, tobacco, and caffeine, sedentary lifestyle, low testosterone level in men. Other symptoms, the dowager's hump, the outward curvature of the upper spine, kyphosis of the dorsal spine, loss of height, pathological fractures, and compression fracture of the spine can occur. So, osteoporosis safety is key. We want to keep the bed low. If they need any assistive devices, we want to make sure that they are of the right height for that, okay? Avoid using throw rugs. They need exercise, a diet high in vitamin D, protein, and calcium. 20 minutes of UV exposure a day. What's that for? Vitamin D and the calcium vitamin, okay? And the DEXA screening, okay? Or the bone density testing, okay? Drugs they use are the biphosphonates and then some of the selective estrogen receptor modulators. Let's answer this question. Correct answer is 1, osteoporosis, because she needs those categories. in autoimmune disease, you will see the deforming of the joint, at the joint, because that connective tissue, okay, that's affected. It affects the young to middle age, usually more female patients are affected than male patients. And it affects the small joints first, then it spreads to the larger joints. Joint pain, stiffness, it may decrease with use, decreased range of motion, elevated erythrocyte sedimentation rate, positive rheumatoid factor is seen in 80% of the clients, and narrow joint space. So drug therapy, high dose aspirin, high dose aspirin and NSAID use, okay? High dose aspirin and NSAID use is used because it does help with the pain and the inflammation, okay? Now, systemic corticosteroids can be given, and then those disease-modifying anti-rheumatic drugs like methotrexate, okay? Sulfasalazine, hydroxychloroquine, that's just a few, okay? We also have other management, non-pharmacological, like hot and cold therapies that can be used, okay? Weight management, rest the joint, shower chairs, okay, our assistive devices, canes, walkers, and straight back chairs, and elevated toilet seats. Lupus. There are two types. You want to know that there's discoid lupus that only affects the skin. You want to know systemic lupus that affects, as you see that picture there, the entire body. Major triggers for lupus flare-ups: sunlight, infectious agents, stress, drugs, and pregnancy. This picture, you see the discoid lupus. It affects the skin only, and the hallmark sign is that butterfly rash across the cheeks and the bridge of the nose.
That's not, religion?
It's a sign of the discoid lupus, okay? And it's like the butterfly, okay? Yeah, think about rosacea can be anywhere, but lupus is like a butterfly. That's a hallmark sign. This will only discoid lupus. Only discoid lupus. What's your question?
This seems like I remember it being another, disease that I also have that butterfly. That's the only one that has.
Only one that has butterfly. Rosacea can be seasonal, if that's what you're thinking about.
No. It's the actual butterfly rash. It seems like it was another disease that we went over.
They talking about lupus.
Oh, it says lupus.
Right, it is.
Oh, this is discoid lupus. Okay. And I was gonna say, okay, so systemic lupus, we have joint pain, fever, nephritis, and pericarditis, okay? Photosensitivity. So again, you're teaching drug management, taking their medications, full course, disease process, conserving energy, avoid exposure to ultraviolet rays, avoid and reduce stress, okay? Use mild soaps, creams for skincare, steroids for joint inflammation, therapeutic exercise, and heat therapy and pregnancy counseling. Let's answer this question. disease, osteoarthritis. As you can see, the cartilage between the bones starts to deteriorate, okay? And it could be bone on bone. So joint pain increases with activity, morning stiffness, crepitus, limited movement, joint enlargement. That's what you might see. So weight reduction is key, okay? Decrease excessive use of the involved joint, use proper body mechanics. You want to keep the joints in a functional position. Hot and cold application for pain and stiffness, NSAIDs, opioid, analgesics, and intra-articular corticosteroids. Okay. Primary open-angle glaucoma. Okay, glaucoma is considered a silent thief of vision. So drainage channels become clogged with primary open-angle glaucoma. Okay, the aqueous humor flow is reduced in the trabecular meshwork. It's normally painless until the later stages, and then there's loss of peripheral vision. So when we're looking at primary open angle, it's usually painless. Primary angle closure is an emergency, it's painful, there's sudden excruciating pain, and the bulging lens. Okay, they might see halos around lights. And it's diagnosed with a tonometer because that's how they measure the intraocular pressure. So, keys to management. If there's increased intraocular pressure, we want to decrease it. Usually, there are eye drops that are used. Reinforce teaching from the clients and family of proper eye drop installation, acute care for angle closure glaucoma. Okay? And then they can fix that with surgical procedures, laser iridotomy, okay? Or a surgical iridectomy. And then I talked about the eye drops, okay, that decrease the ocular pressure. Let's answer this question. So it's a positive question. What should the nurse do first? So the correct answer is 2. So you have to know how to instill eye drops, okay? It's not in the inner campus. If you put it in the inner campus, it's going to run into the sinus cavity, okay? It's right here in the middle of the conjunctival sac. That's where you instill the eye drops, okay? Cataracts are a clouding or an opacity of the lens. It could be from trauma, aging, or a congenital defect. Early signs of cataracts, blurred vision, decreased color perception. Late signs of cataracts, double vision, and clouded pupils. Okay? As a nurse, you're assessing the medications they may be taking, eye drops. You want to stop anticoagulants before therapy. They can have the cataract removed. Okay? Wear the eye shield when sleeping postoperatively. Avoid lifting anything over 10 pounds postoperatively. Do not lie on the operative side postoperatively. Report signs of increased intraocular pressure and acute pain is an abnormal finding post-op. They need to call their doctor after that cataract is removed. If they start having acute pain, they need to call their doctor. Okay? A detached retina is an emergency. Okay? Patients say it feels like a curtain that's falling over their visual field. Okay? And it just doesn't black. They can see black spots, floaters, bleeding can occur with detachments. Retina repair is repaired surgically. You want to keep an eye patch over the affected area. Now with trauma, determine type of injury, early notification to your healthcare provider. Okay? Never attempt to remove an embedded object from the eye. Let the doctors do that. Okay? Irrigate the eye if a chemical injury has occurred. Okay? Now with hearing loss, there's 2 types. You have conductive and you have sensory neural, okay? Conductive sounds don't travel to the inner ear. They can benefit from a hearing aid. It can also be due to cerumen, earwax buildup, okay? Sensory neural hearing loss, sounds are distorted by inner ear defect, sensory neural defect for hearing loss. Okay? Some common causes, infections. We talked about drugs yesterday that can be autotoxic, gentamicin, vancomycin, and furosemide, okay? Autotoxic drugs. Symptoms of hearing loss, the patient cannot hear that whisper test from 1 to 2 feet. They're shouting in conversations. They're turning their head to favor one ear, and then there's a loud volume on their television. So when you're speaking, face the client. If they got accustomed to reading lips, in the event you don't have a face mask on. Wear hearing aids. Make sure that they have their hearing aid. The battery is good. Okay. They have glasses if they need glasses. Speak in a normal tone. Enunciate your words. Rephrase questions, and do not cover your mouth when speaking to them. Let's look at this trend, drag, and drop question. And so fill in the blank. Okay. Go ahead and review it and answer it, and then I'll let you all see that answer.
Correct answers are: the client is most likely experiencing increased ICP as evidenced by the presence of Cushing's triad. The presence of Cushing's triad. Let's go ahead and take a 10-minute break. Be back at 11:30. You'll start chapter 9 before you go to lunch.
That's my son. What did you do when you were in last year? He goes, Dad, I want to charge. I said, I want to get charged.
Oh, yeah.
Because he loves it. I said, okay. And then, like, he wanted me to find out. He wanted to do Israel, Germany. I said, I'm like, we'll just do the United States. We're in the U.S. And so, but he wanted to charge me. So it's like, I'm fine. What's the longest? What's the longest in South America? I'm just like,
Dude, that's about as off as my,
this is a bottom like this. It's like, all right, and it's like, they can quizzes and ask all these questions. And you can hang out like this bonus stuff. And when I said that's what I said, it's just like, oh, else to do. I want to make this world. It's
That's
like
what
a,
decorations you want?
it's basically like a carpet.
What decorations do you want?
Well, I just want this weird. I tried to do a really good because when I was looking at the world, they had them with like all the flags and everything.
Yeah.
I broke. Jesus, but
I'm like, I'm gonna like have a picture over the next couple months. And then luckily, she switched it to Minecraft, but it's recently.
So like we can do like provision one, where wherever it says, and then the comma, so according to whatever looks like that was that. We do a comma. It's not as strict as according to according to the American
But at the beginning of the year, she said it was.
What format we gotta write the essay in?
APA 7th edition.
That's the reference and the papers, APA 7?
We could probably put together do some other stuff. Yeah, because she wanted the questions in class, and I remember she said, like, yeah, you do research or just try your best, just get the ones that are directly. She said she would revise it to make sure there was none that were directly associated with the daycare.
So I think I recognize
I'll give you an example.
Yeah, this was really
it's not APA. What's the name of the format before us write the actual paper?
It's an APA.
Not the not the citing, not the citations, but the actual writing.